I would like to shed some light today on the detection and management of late onset intrauterine growth restriction. My knowledge increased tremendously when I actually went into all the details and all the articles and all the new evidence and development that is out there, and I'm hoping to shed this light with you today as well. I would like to start off with an article by Gardosi et al. That is titled "The Maternal and Fetal Risk Factors for Stillbirth." It's a population-based study. What they have done, they looked at over 92,000 normally formed singletons and about 400 stillbirths from 24-week gestation. And they wanted to see what exactly is a factor that has got an increased risk for stillbirth in this population. The slide is quite busy, so I'll just highlight a few points. As part of their results, they found that as potentially modifiable risk factors, that maternal obesity, smoking in pregnancy, and fetal growth restriction together accounted for 56.1% of all the stillbirths in their population study. Their conclusion states that most normally found singleton stillbirths are potentially avoidable, and the single largest risk factor for unrecognized fetal growth restriction is unrecognized fetal growth restriction, and a preventative strategy needs to focus on improving the antenatal detection. So what this slide taught me is that many stillbirths, I think even in our population at Tygerberg, go unnoticed. And I'm here to shed some light on how we can increase that surveillance. Intrauterine growth restriction remains one of the most challenging factors in maternal fetal care. And this dilemma is made harder because we don't have the tools to adequately or readily available to diagnose late onset fetal growth restriction. So we need to better identify and define the fetal growth restricted fetus and rather apply the concept of fetal growth potential for that individualized case. Intrauterine growth restriction is associated with stillbirth, neonatal death, perinatal morbidity, as well as delayed effects including cerebral palsy, and it's been proven to have an association with adult disease, namely hypertension, insulin resistance, diabetes, and diabetes in type 2 with obesity. In the absence of any effective treatment for fetal growth restriction, the mainstay of management is close surveillance and timely delivery. Now, I looked at many articles concerning what do they think is the gestational age that we should use as a cutoff for late onset fetal growth restriction. In the American Journal of Obstetrics and Gynecology, they used 34 weeks. In the Australian and New Zealand Journal of Obstetrics and Gynecology, they say between 32 and 34 weeks. But according to Gratakos' study, they looked at when is the most optimum time to diagnose when we should call this baby that a fetal growth restricted baby. And they found that a gestational age cutoff of 32 weeks at diagnosis maximizes the difference between early and late onset fetal growth restriction. So we should always take note with regards to labeling a fetal growth restricted baby as just a constitutionally small baby. Overall fetal smallness is associated with poorer outcome. I will show you a few slides with regards to that. And fetal growth restriction is normally referred to small fetuses with Doppler signs suggesting hemodynamic redistribution, whereas the small for gestational age subgroup of small fetuses that do not present with these abnormal Doppler findings are said to be constitutionally small and have similar outcomes to their normally formed fetuses or to their full-grown counterparts. This is a slide by Gardosi or by Gratakos, where they just said that we should just be very careful with just labeling a baby that's constitutionally small with normal Dopplers as just being small for gestational age with a potential normal outcome, as many studies have shown that there's a significant increase in the risk of adverse perinatal outcome, as well as an increase in the risk of adverse neurodevelopment in these babies with a normal umbilical artery Doppler. This is also a slide showing in their population study with regards to small for gestational age, a proportion of perinatal adverse outcomes in just over 350 consecutive cases. They found that almost 10% had neonatal acidosis, about 20% had a seizure for fetal distress. About 25% had an abnormal neonatal behavioral assessment score, and 40% almost had another complication. So let's talk about the detection and the screening for this intrauterine growth restricted baby in our setting, in our level 2, level 3 setting. It's very important to note the previous history, that the patient might have had a growth restricted baby or previous stillbirth. With such cases, there's about a 50% increased risk of a severe growth restriction in the current pregnancy, and more than half of normally formed stillbirths are also associated with intrauterine fetal growth. So this is quite an important population group that we should just increase our surveillance on. With diabetes, it's been seen that with pre-existing type 1 and type 2 diabetes, that they have a 15% increase of having intrauterine growth restriction. With obesity, small gestational age is rather defined by customized centals, as sometimes it's difficult to assess a correct SF measurement for these morbidly obese patients. And studies have found that with obesity, it increases the risk by about 50% of that pregnancy being small for gestational age or having growth restriction. And then, of course, multiple pregnancy with all the different placental abnormalities that can associate with it. So is there something that we can do to screen these women early in their pregnancy, preferably in the first trimester, to see if they will develop fetal growth restriction, late onset fetal growth restriction? There are biochemical markers which are associated with an increased risk of placental disease, like IUGR or preeclampsia. For example, in the first trimester, in unexplained low pregnancy-associated plasma protein A, or HCG, or in the second trimester in unexplained serum alpha-fetoprotein, HCG, or inhibin A. But there's no clear study to describe its benefit for the late onset fetal growth restricted baby, but more so for the early onset fetal growth restricted baby in association with preeclampsia. What about the future? There has been new articles and studies about maternal or placental RNA in the maternal blood at 28 weeks gestation. This article talks about a study that they look at placental specific proteins and which are secreted in the maternal circulation at between 26 and 30 weeks. And the conclusion was that a unique placental transcriptome is detectable in maternal blood at 26 to 30 weeks gestation in pregnancies destined to develop late onset fetal growth restriction. So perhaps in the future, in a few years to come, this will be one of our mainstay treatments. We'll see. What about the symphysis fundal height? This is what we commonly use as in all our pregnancies. To note that the SFH is just a surveillance tool rather than a screening tool, as its strength lies in serial assessment of the same patient or of the same patient, preferably with the same observer, as we do know that different observers might get different assessments. So there are mixed views with regards to the different studies. A study done by Cardosi showed that there's a significant increase in antenatal detection for small for gestational age. It improves from about 29 to 54%. In a different study by McLachlan et al., he stated that with their study, they felt that it performs poorly as predictor of small for gestational age, with a sensitivity only of 17%, a positive predictor value of 20%, and this is even decreased in obese women. Limitations to SF measurement are fibroids, amniotic fluid index, and descent of the presenting part in late pregnancy. But one should also take this study in context, as they did it in a first world country where there are many resources available, and I feel that this cannot always be applied to our setting. The RTOG and WHO still recommend serial measurement and SFH plotting on a customized growth chart. So now we found a fetus that maybe has got an estimated fetal weight or a SFH on the 10th centile or just below the 10th centile. What we usually do is that we send this patient now for a growth scan. So detecting fetal growth rate is important when the gestational age is established in the first trimester. Many of our patients unfortunately miss that opportunity for the first trimester ultrasound and do present in the second trimester. But once we look at that second trimester ultrasound, we must be very careful to also assess that the baby is not already growth restricted at that second trimester ultrasound. So the transcerebral diameter is also useful in determining the gestational age. And like I said, we define small for gestational age babies with the estimated fetal weight or abdominal circumference less than the 10th centile, and sometimes also say with a head circumference to abdominal circumference ratio above the 95th centile. Now, with regards to a growth chart, where do we plot this fetus after we've done the growth chart? There are different growth charts, one being the population-based live birth weight chart, intrauterine fetal growth chart, and a customized fetal growth chart. This was quite interesting to me as I didn't really pay particular attention to what we usually use and what evidence shows. So which chart do we use? What does the evidence say? I will just go on to the numbers of this study, so don't look too much at the values. This is just an intrauterine growth chart versus a live birth weight chart for the 10th centile, which could be associated normal or small for gestational age. Basically what this study shows is that when we use live birth weight charts, and then it can underestimate some fetuses or can misdiagnose some fetuses as being growth restricted, even up to 35 weeks of gestational age. Because in a live birth weight chart, the growth of the baby being the 10th centile, a premature baby being the 10th centile, is already a pathological finding why a baby is born prematurely, and now we're taking that baby centile and comparing it to a normal in utero fetus. I don't think, or the study shows that that is not optimal, using a live birth weight chart, especially for prems less than 35 weeks. What about customized fetal growth weight charts? The Intergrowth 21st study is quite a new study. The Intergrowth stands for International Fetal and Newborn Growth Consortium of the 21st Century, where they looked at many populations across a few continents, and they tried to combine a growth chart to adequately diagnose fetuses that might be at risk of a growth restriction. I don't think, sorry, it's not projecting too well, but what they found, this is a New Zealand study, is that they compared if they used Intergrowth 21st versus a customized growth chart. They found that the Intergrowth birth weight chart missed on a few of the small for gestational age fetuses, especially in the obese population. So they felt that using a customized chart in a few instances might benefit the patient more, and also to actually look at your population that you are applying this growth weight chart to, rather than just saying, let's just use this international chart and apply it to everybody. Now, we usually send the patient for Dopplers or do Doppler studies on the baby. For late onset growth restriction, it's been found that the umbilical artery Doppler as a standalone is not valid anymore, as studies have shown that we need to look further into other Doppler studies of this fetus as well. Umbilical artery Doppler identifies severe placental disease, but it fails to pick up instances of mild placental disease. And evidence shows that during the last 2 decades, small for gestational age defined by a normal umbilical artery pulsatility index contains a large proportion of fetuses with worse perinatal outcome than normally grown fetuses. I will show a chart to illustrate this just now. So despite the limitations of the umbilical artery Doppler, what's more important to look at in these late onset growth restricted babies is the redistribution of the fetal circulation. So it's not a new study, but what's very significant with fetal growth restriction of late onset is the cerebral-placental ratio, which is the middle cerebral artery pulsatility index divided by the umbilical artery pulsatility index. This ratio amplifies the effect of subtle changes in placental resistance and fetal vasodilatation. And the CPR, or cerebral-placental ratio, has also been shown to improve sensitivity for detecting adverse outcomes. That is the perinatal mortality, admission to neonatal ICU, a low 5-minute APGAR score, and cesarean delivery for fetal distress. Other Doppler parameters that we can use is the uterine artery resistance, which does marginally improve the prediction of adverse neonatal outcome for the late small for gestational age fetus. There are other cardiovascular Doppler measurements, which is usually used with the early onset fetal growth restriction, and not so much in the late onset fetal growth restriction. But in early onset, it does have quite a remarkable outcome with regards to the prognosis of fetuses. With these two charts, it compares only using the umbilical artery Doppler versus if you use the cerebral placental ratio, uterine artery pulsatility index, or the estimated fetal weight less than the 3rd centile. With the first chart on your left, they only use the fetal growth restriction defined by umbilical artery pulsatility index above the 95th centile. So more or less in the middle of that chart is about 30, 31, 32 weeks. And in the navy blue bars, it shows the amount of, or the number of fetuses that were identified at that point with an abnormal umbilical artery Doppler and being classified as fetal growth restriction. But with the chart on the right, if you incorporate the cerebral placental ratio or the uterine artery pulsatility index and estimated fetal weight less than the 3rd centile, we pick up many more of these fetuses with fetal growth restriction using these other Doppler parameters. What about the amniotic fluid index? Experts vary in the significance of oligohydramnios in the small for gestational age fetus. There has been a PORTO study, which is a pediatric study. PORTO stands for Prospective Observational Trial to Optimize Pediatric Health in Intrauterine Growth Restriction. They looked at different parameters, the estimated fetal weight in utero, the umbilical artery Doppler in utero. But with regards to the amniotic fluid index, they said that oligohydramnios minimally improves the prediction of adverse perinatal outcomes, except for when the estimated fetal weight is less than the 3rd centile, that it has got a more positive predictive value. However, this is what we already do. When assessing amniotic fluid index in the growth-restricted baby, the cutoffs are with a maximum vertical pool of less than 2 centimeters and an AFI less than the 5th centile at that gestation that it's been done. So now we have identified the late onset fetal uterine growth, intrauterine growth restricted baby. What do we do with this baby right now? So it depends on the gestational age of the baby, the fetal condition that we will determine by the Doppler findings, and the maternal or obstetric comorbidities also associated with this case. Principles of management is to differentiate the fetal growth restricted baby from the constitutionally small fetus, and to minimize the risk of iatrogenic preterm birth and adverse neonatal sequelae. This is just a slide also from Gratakos where he shows the differences in management as depicted by the DigiTat trial. The DigiTat trial was a multi-center randomized trial where the primary outcome was looking at adverse neonatal outcome, and the secondary outcome was to look at operative, which is vaginal or instrumental delivery or cesarean section, to look at that outcome. With regards to this study, it showed that induction of patients close to term versus expected management close to term has got very minimal differences. And they felt that if a patient can be rather managed to have expectant management and to be delivered at 40 weeks, has got the same outcome as what if a patient had to be induced earlier. But the author's conclusion, who wrote the DigiTat or who commented on the DigiTat trial, said that despite the lack of differences, it's irrational to choose induction to prevent possible neonatal morbidity and stillbirth. There's a lot going on this slide as well, but basically what it is, it's a protocol that is integrated to classify the babies or the growth-restricted babies according to stages, and this protocol helps us to say when or to determine when to deliver the fetus. I will not go too much into it, but it's quite a conclusive or quite a comprehensive flow diagram as to when you should deliver different gestations and with different abnormal Doppler findings. So what we do at Tygerberg, sorry, this is also not projecting too well, but this is the Tygerberg protocol for management in patients with small for gestational age. So basically, what it says that if the fetus is less than the 10th centile, and then we divide it into the fetus that is small for gestation versus the fetus that just has got normal Dopplers. I'm not going to go too much into the slide. It's quite self-explanatory. And what I found is that this slide is also comparable to international standards as well as to other protocols that we use, or protocols that is being used in the American College and also Australian and New Zealand College for induction of labor or management in the small for gestational age babies. Sorry, this is even worse. It didn't look as bad here. This is McDonald's and McCarthy. This is just an Australian and New Zealand journal of obstetrics and gynecology, and they have also proposed a management with regards to when to deliver these babies. But usually what they do is that they put patients into different pathways or different boxes, saying at which umbilical artery Doppler what one should do. So then they put the baby in a pathway A, pathway B, and they decide as to when to deliver the babies. Usually delivery at 36 weeks if the Dopplers remain marginally normal, but also saying that we can continue to term. I think I would rather just forward these slides to everybody, as the management protocols are not clear on these slides. In conclusion, late onset fetal growth restriction is the single most important contributor to term stillbirth. And detection of fetal growth restriction has been shown to reduce stillbirth risk, and so should be a priority in antenatal care. Once suspected, ultrasound assessment can assist in differentiating the growth restricted from the constitutionally small fetus. And features most significantly associated with adverse outcomes are severe growth restriction below the 3rd centile and evidence of brain sparing. Okay, here we go.
Thank you very much. This is a very important topic. It was really hotly debated at the recent Priorities Conference. The protocol we follow at Tygerberg, can't you just go through it with us so that we couldn't read it, but if you can go through it with us, I think it will give us an idea of what is being done presently.
I'm trying to get a better image of it on my computer. I wonder, perhaps, Mr. Marburg, I've got one in a nice PDF, a Word PDF that will project quite nicely onto the screen. Is it possible to help me with that? So I want to project this onto the screen. It's just not projecting.
Okay, it is quite a lot to. I don't have it off by heart, but basically your management is based on the abnormal findings at each specific gestational age. So criteria for delivery at 30 weeks would have to be a lot more severe placental disease than delivery at 36 or 38 weeks, if you can just get that principle. And at each time you assessing the baby, you would, so late onset IUGR is mostly associated with normal umbilical Dopplers. So each time you would look at the growth velocity of the baby and see that there has been interval growth and the velocity is not plateauing off. You would look at the AFI. Also, you would look at CTGs and the degree of abnormality in the CPR would then, and gestational age would then help you determine the frequency of your surveillance and when to deliver. So it's quite gestational age specific. Okay.
As I understand it, we now depend on ultrasound weight estimates. In other words, if you want, and that's probably done up at the high-risk clinic. And then those that are below the as soon as a baby falls below the third centile with regards to the weight estimate, then CTGs are done. If the Dopplers are still normal, in other words, you don't rely on your Doppler, but now you're actually relying on your CTGs. And that's, I think, what's sort of in that flow diagram, because we were discussing that quite a lot last year. And my suggestion was, can't we add an additional Doppler criterion at the fetal evaluation clinic, because we've got the right tool there, we've got a pulse wave Doppler there, and it will be quite easy, for instance, to also do a middle cerebral artery Doppler, and not only rely on the umbilical artery Doppler, but Professor Geertz, who was unfortunately not here, said it won't solve the problem. You have to do quite a few more than that. Therefore, because if you use screening tests, it's good to have a once-off thing. In other words, you do one thing. If it's normal, okay. If it's not normal, you do the next thing, and if and just use screening methods like that. But unfortunately, there isn't a once-off Doppler if the baby is quite small and the umbilical artery Doppler is still normal, and the pregnancy is reasonably advanced, and that's why the weight estimate now comes into play, and that has resulted in quite an increase in the number of CTGs done at the fetal evaluation clinic. But that is more or less how I understand it. I don't know if you want to comment further.
I think the issue with the Dopplers is it's consequential testing, so that if one Doppler is abnormal, then you move on to the next one. So that's umbilical, and then MCA, and then ductus, and then aortic arch. But the issue is you would need quite a lot of skill and also the time taken to scan all of these patients, and I think that has major implications for service provision. I think one of the things which could be useful in raising red flags that you start to, the definition of SGA is the old definition was less than the 10th centile, but when you get to a baby that's becoming less than the 3rd centile, that baby is more at risk than a baby between the 10th and the 3rd centile. So that is one thing that you could look at. But it's not as easy as saying, well, let's do one test. You have to do those tests sequentially and put the whole picture together. And actually, Gratikos, who is one of the world experts on late onset growth restriction at the moment, he's actually come up with a calculator which is free on the Fetal Medicine Barcelona website, where you can just put in gestational age, weight, the Doppler results, and it will tell you exactly when to repeat the Dopplers and when to deliver. So, and he's asked his consultants and registrars not to use their brains, do not think in the labour ward, just put it into the calculator. He actually said that.
If we go back to the CTG, how bad is the CTG? How bad is the CTG?
I think interpreting CTGs in late preterm and term is a lot easier to do, because you should have a very good quality of variability with accelerations. I think the difficult CTGs to interpret would be the early onset preeclamptics with prematurity, makes it occasionally difficult to interpret the CTG. But typically, late onset IUGR babies aren't at risk of antenatal deaths in utero. It's actually the longer term neurological consequences, and they also decompensate when in labor.
Yeah.
So it's the same CTG criteria as we would use for late preterm babies, but remember, these babies don't usually die spontaneously antepartum. They usually decompensate during labor.
That shows the variability of the most important factor. Because that will give you the best indication of let's say, brain function. If I could take a...
The thing is that at 32 weeks, you should have really quite well developed. So I think you'd have to look at it. I think you would use variability as a stronger factor in the early onset preeclamptics. Because a 32-week baby should have quite comparable variability to a term baby.
Also, that we some just instant about to bring into the picture accelerations. Because you don't always have accelerations. And how many would one want to start delivering for the lack of accelerations? It might not be the right thing either. Okay, we're still ready to
Yes, I do have the protocol on screen now.
Okay, so we'll ask Praveen just to run us through that.
Sorry about that. So with a SF less than the 10th centile with a normal umbilical artery Doppler, we verify that there is correct dating and do a high-risk clinic growth scan. If it's a small for gestational age fetus, meaning the estimated fetal weight less than the 10th centile, or head circumference to the abdominal circumference above the 95th centile, or abdominal circumference less than the 5th centile, we divide it into two groups, less than 28 weekers and more than 28 weekers. Less than 28 weekers, we repeat the high-risk clinic growth scan and fetal evaluation clinic Doppler at 28 weeks. If the baby is more than 28 weeks now, we repeat the Doppler, blood pressure and urine every 2 weeks and send the patient home with a daily fetal kick chart. I'm just going to scroll up. If we find with a growth scan then at 28 weeks that the estimated fetal weight is less than the 3rd centile, it's got two nice flow diagrams that we can follow. Less than the 3rd centile with a Doppler remaining normal and no evidence of preeclampsia, we repeat the high-risk clinic growth scan at 34 weeks. Then, if there's adequate growth trend and a normal LICOR and reactive CTG, we aim to deliver at 36 weeks. If there are clear signs of slowing of growth or reduced LICOR, we do the CTG. I'm just going to follow down for completeness of that trail. So if the CTG is reactive, we repeat the CTG at 35 weeks and we aim to deliver at 36 weeks. If the CTG is non-reactive, twice on the same day, we admit and consider delivery. So that's the one arm. After the 28 weeks gestation, if the estimated fetal weight is between the 3rd and the 10th centile and the Doppler remains normal, no preeclampsia, we repeat the high-risk growth scan at 36 weeks, and if we then find that it's below the 3rd centile or clear slowing of the growth trend or reduced LICOR, we do a CTG, and that follows the same pathway. Whether the CTG is non-reactive, twice on the same day, admit and discuss or consider delivery that day as well. If the growth is still between the 3rd and the 10th centile, and there's adequate growth trend and normal LICOR and a reactive CTG, we aim to deliver at 40 weeks. With regards to the less than 3rd centile, if the CTG is reactive, we repeat the CTG at 37 weeks, and depending on the CTG, we either deliver at 38 weeks or deliver on the same day.
So that's what you sent me that one predicted much better than reading your slide.
Yes, I'm really sorry about that.
It's very easy to read it up.
It looked much better on my
CTG,
screen.
just for my own name, is that in 2 accelerations per 10 minutes, 2 adequate accelerations per 10 minutes or not. Because that was the old definition. I don't know if in your days, Prof. Urnal still said die son mag nie sak op 'n non-reactieve VFM. That was really bad if you had that.
I do think good variation CTG without accelerations will also be accepted as well.
So I think we've got to get that terminology that one decides about that. Is there anything new? Because there is a rep that's going to see us.
Just a quick practical question. It all starts with an ultrasound scan and with a ratio and with an estimate of bed and adult. Do we have tables up in our estate? How do we calculate those things? Registration.
On the ultrasound machine, there is chitty charts itself, but there is graphs.
And that's available, and that protocol is up in the clinic.
Was?
I don't know.
I just have one question in that study where you showed the sample size of 600 patients and when they were managed either delivery at 38 weeks or expectant management and delivery later. In the first group, the majority of them were induced and then later developed fetal distress. So at that stage, they were relatively well if they could be induced. But in the second group, 50% of them developed fetal distress. So some of them would have developed unprovoked fetal distress. And then to just look at neonatal admissions is maybe not a good indication of outcome. If those children are followed up after 2 years, then maybe they waited until the child decompensated. Where the other ones was delivered before they decompensated. I don't know, what's your opinion on that?
When one looks at the results of the Digitat trial as to when exactly they were induced, or the expectant management versus the induction group, there was only a difference of about 10 to 11 days. So that's not too long of a difference, I feel. They showed similar outcomes if the patient was induced versus managed expectantly. But that also proves that with a late onset fetal growth restricted baby, once they have got the stimulus of labor, or once they have got this, once they are challenged, these babies actually don't tolerate well to labor. And that's why they didn't find any similar or marked differences between the two groups being induced or being managed expectantly. I hope I answer your question.